Hello and welcome to the professional series webinar for the Christopher and Dana Reeve Paralysis Foundation. I'm very happy to have a guest today who is Associate Professor of Physical Medicine and Rehabilitation at Johns Hopkins School of Medicine and the Clinical Director for the International Center for Spinal Cord Injury at Kennedy Krieger Institute in Baltimore. She cares for both children and adults, so this will be a nice segue to cover the whole age spectrum here. And her philosophy is in functional restoration through activity, and she promotes care through major paralysis organizations. So she's involved in a lot of things. And full disclosure, my personal friend, Dr. Cristina Sadowsky, welcome.
Well, thank you, Linda, for having me. I am really, truly honored, not only because we have a history together. I started my career in spinal cord injury under your guidance, but also because I get to talk to all these wonderful human beings from this platform that has always been on the side of outstanding research and care in individuals with spinal cord injury, the Christopher and Dana Reeve Paralysis Foundation. So thank you.
Absolutely. So let's begin and start by talking about how you got into this world of spinal cord injury and paralysis.
Well, my interest got sparked by coming in contact with researchers that kind of helped me visualize the bench to bedside spectrum of intervention in spinal cord injury, of research and care. The evidence for this therapeutic induced behavioral modifications and recovery at the experimental animal model provides to be a very, very strong basis for application into the clinical care. So we know now that the changes, activity-based induced changes, don't only do behavioral modifications in individuals with spinal cord injury, meaning not only improve motor or sensory function, but also change at the molecular and metabolic level the residual structures and functions in the central nervous system and peripheral nervous system and autonomic nervous system. So with that in mind, having the example of bench to bedside and having the availability of bench with this one researcher, Dr. John McDonald, that was able to transition from the animal model, make me as a clinician understand that whatever we see at the mouse level, at the injured mouse, part of it we can translate directly to the clinical care. I'm a clinician through and through. So for me, yes, it's about research, but it's about improving the life of individuals with spinal cord injury. So whatever it takes, and if I understand the basic science, I'll get there.
All right. So yes, whatever it takes is what we're happy to do. So can you talk about this activity-based program and just tell us what the fundamentals are, how it works, what it consists of?
Well, yes, sure, of course, I can. So there are multiple ways of, improving neurologic function following a neurologic injury. And the easiest part of improving function is optimizing spontaneous regeneration. We know that spinal cord injury induces a tremendous drop in the amount of activity in the central nervous system. So activity-based interventions are aiming to restore a certain percentage of this lost activity, because we know that activity is at the basis of myelination and remyelination, and function restoration, the basis of new cell birth and synaptic connection. And now if I try, obviously it's easier to explain it with memory. If I try to remember a music sheet, I will practice and I'll create those synaptic connections, and I will be able to reproduce that in a very easy way, motorically. When you have a neurologic injury, that is not as easily achieved, but it still depends. If we down-regulate the level of neurotransmitters, we are never going to progress or restore any movement, any sensory function. So raising the level of activity somewhere on that optimal curve is part of what should help the nervous system heal. Now, I'm not saying regenerate, I'm saying restore function, because we also know that we don't need 100% restoration of the anatomical structure in order to obtain the function. There are so many statements of how much of our brain we use daily, and I can tell you that I vary in between 0 if the subject of the podcast is not interesting to a lot more, probably 50 or 60% if I am trying to create or participate actively in a talk. So activity-based restorative therapies are basically, or activity-based rehabilitation or activity-based therapies employ activation of the nervous system above and below the level of the injury in patterns that are congruent with previous motor patterns in order to restore, not compensate for the lost function. That's the kind of a general principle. We use a bunch of interventions. We define 5. ABRT or ABR or ABT are based on the 10 neuroplasticity principles. We use 5 different interventions, and one of them is electrical stimulation or functional electrical stimulation, and/or the other is weight loading, locomotor gait training, task specificity, and massed practice. Now, those are the principles. They're simply put in 5 interventions, so it's easier for whoever, the therapist or the clinician, to apply them. But they, you can use, you can add neuroplastic intervention, and we are like spinal stimulation, CNS stimulation generally, acute intermittent hypoxia, aquatic training, and so forth to complement or be part of this 5 specific interventions.
Okay, and there's some rehab interventions that will be put out there on the chat box, so you can look at those also and get more information if you would like to have that. So when you do this activity-based recovery program, you do it for adults, but you also do it in children. And can you talk about the differences in caring for those 2 populations, because they're not the same and they each have their unique needs?
Yeah. And you're going to hear it for everybody that does pediatric rehabilitation generally, that a child is not a small adult. Right. We all know that. So traditionally, we look at children as having a more plastic nervous system. And I am not here to argue pro or against that. That is one of the 10 neuroplastic principles, is that the younger you are, the better it is for restoration of function. But I do want to underline the fact that everything is in change when we're talking about the little guys. Everything from the central nervous system to the acute, to the autonomic nervous system, to the musculoskeletal system. And we don't do always rehabilitation, we do habilitation, meaning we acquire function as opposed to we restore function. Another thing that I want to mention is the fact that traditionally the spinal cord injury models system of care are focused on adults. Thus, research for children with paralysis is very much smaller in sense and intensity. And there are limitations into when you enter a child into a research protocol. So what can I say about pediatrics is that there is no limit to what you can achieve, kind of a philosophic principle, because there is no limit. You don't know what the potential of that child was prior to injury. We think that the nervous system is more adaptable to change. We habilitate, don't rehabilitate, and we need to do more research.
Absolutely. So, sometimes we'll have parents that come in and they'll say, oh, look, my 3-month-old is sitting up independently. And they'll think, oh, look at how advanced my child is. Whereas as the practitioner, we'll see, well, they're sitting up because they have this intense spasticity, because developmentally wise, 3-month-old children generally do not sit up on their own. So sometimes there are those little differences in what is traditionally normal. Not that your child can't be advanced and might sit up at 5 months instead of, some other time, that certainly happens.
6.
Yeah, but on the other hand, there certainly is a lot of potential with children, because you don't know how far their development is going to go once you stimulate their nervous system. So you can really do a lot of things, because you have a lot of potential there, because
definitely
developing that nervous system, as opposed to having a more fixed nervous system, although nobody's is really fixed, but compared to adults, it's more stagnant, let's say. Then children have a lot more opportunity for getting things going. So what do you see in the differences in caring for children versus caring for adults, as far as like timetables? Do you see progress being more quick? Do you see maybe more difficulty because of level of understanding of a child versus an adult can understand what the process is that's going on, where a child thinks, well, I'm playing with this little ducky, so leave me alone. Do you see huge differences in the populations?
So if I look at the data, because we looked at the data from our center from a strictly neurologic point of view, the changes, let's say conversion of Asia grades, are similar in adults and in children, undergoing similar interventions. They are activity-based interventions. So conversions, neurologic gains are the same, but like children are fearless. So the ability to rehab them is actually quite more extensive, because they do not have this inhibitory neurotransmitters that are generated from their own thinking. And yes, we have a lot more goals to achieve, because each level of growing comes with different goals. So while you were talking about, achieving sitting, neurodevelopmentally, yes, we have to achieve we're striving to achieve all the motor goals. But as we move into pre-K and K, we're going to start having to deal with complications and comorbidities that are associated with growing. So because they grow, children that are injured early in their life, they develop scoliosis that will 95% of them will require surgical intervention. They will develop other musculoskeletal problems related to formation of the acetabular of the hip joint. They will develop if they weren't able to achieve ambulation. And I'm going to be really poignant here. If the child got injured before they achieved the ambulation, that doesn't stop us practitioners to teach them to achieve ambulation, because there are these consequences that happen when a child doesn't do weight bearing. That's why one of the 5 principles of ABRT is weight loading, because weight loading is essential in skeletal development. So there are all of these phased goals that require ongoing rehabilitation. You never discharge a child. Well, you never discharge an adult with a spinal cord injury, if you ask me. You allow them to go home and practice on their own, to accumulate more and more activity so they can make that step, that improvement to the next neurologic level. Or if they are in an aging period, they prevent the rapid decline, which is what we're seeing. So, you know, I'm a PM&R doc. I'm going to tell everybody that you need to have a therapist, and you need to go to therapy for life, on and off. Mm-hmm. You can use resources. You can call it a trainer. You can call it a personal movement group in which you get together with other people that know principles of neuroactivity. But you have to continue moving. Activity is not a luxury. Activity is a need, the same like you need to eat well, you need to sleep well, you need to move well. And people with spinal cord injury do not have less of activity needs than able-bodied individuals, but more, because we talked about the fact that spinal cord injury decreases the activity level. So I think I kind of went out on the periphery with this, because we started with the children, but the point is that there is ongoing need for medical rehabilitative intervention. In children, it is staged according to their developmental stage. And in adults, needs to continue. So as they progress to adulthood, that changes too, because they move from school to employment, and those are different needs from both socioeconomic, but from a mobility and ADL point of view. And then as we age with spinal cord injury, what we've seen, there is this big drop at some point. So you hold steady, and then you drop, because all those comorbidities are accumulating under the level of inactivity induced by you being in a chair and saying, hey, yeah, I'm sitting in a chair, and then you drop down, and that's when your shoulders give up on you, and that's when you have myelopathies and decrease in increased spasticity, decrease in neurologic function, increase in neuropathic pain, decrease hand function, so forth. And that all gets colored really gray with depression. And that is another down regulator. So activity upregulates all of those. We have about 9 biochemical structures that are neurotransmitters, classes of neurotransmitters. We do everything with those. 9, we think, we love, we move, we feel. Spinal cord injury affects all of them. Activity is helping upregulate most of them.
So what you're saying is, even though we have these developmental stages as children, we have developmental stages that we go through our whole entire life that are not, some of them have been defined, but they're not as clearly defined as children, because children gain so much abilities as they go through their life. Like we were talking about, sitting, standing, walking, you know, those all things have talking. Those are all things that you can see, you can hear, you can observe a child doing those. As adults, you might not see those activities or the developmental stages going through as quickly, but they're happening. They're happening to us all.
They definitely are.
Changing. We're humans. We're constantly changing. We're always doing something different. So in your work, what have been the big discoveries that you have found by adding activity to people's lives?
The big discoveries. Well, I guess the big discoveries that improve function, because for me, again, the goal is improving function. And the way to achieve it is not by compensation, but by restoration. So those are like well-defined principles. What excites me at this point are this couple of neuroplastic interventions. So I practice the ABCs: activity, biologics, and well, I call it computers because it works like C's, but it's technology. I think that those three are interventions that will improve function in individuals with paralysis related to spinal cord disease. I personally only have knowledge in the A's and the C's. And in the A's, activity is being, what am I excited about these new discoveries are the CNS or nervous system stimulation, and it can be single stimulation, transcutaneous or epidural, or it can do multiple site stimulation, starting from the brain with TMS or TDCS and continuing with the cervical or spinal, or combining peripheral nerve with spinal stimulation. So this is a very strong neuroplastic interventions that is actually improving function. And the other thing that I am really excited about is the acute intermittent hypoxia, which has incredible data for incomplete spinal cord injury. But so we just need to figure out how to dose all this intervention. So when you ask me about discoveries, well, discovery is getting better function or preserving the function as we age. That this is the goal. There is no other discovery that, you know, I would love to say that we can technologically or biologically construct a new spine that we can implant it in and replace, you know, do a spine transplant. But, you know, it's not going to happen during my lifespan, despite the fact that I exercise and eat well. I'm not going to live so long. But the activity and neuroplastic interventions that I mentioned are creating improvement in neurologic function now. So that's very exciting as a discovery.
And there's a lot going on in the electrical stimulation. I think a lot of the listeners will know about that. Talk a little bit more about the intermittent hypoxia, because that is a bit newer and it's not really out there that much in the general community. So can you tell us more about that one?
Yeah, it's applying. So technically, when you go to therapy, it's applying a mask that limits the amount of oxygen. Room air oxygen is 21%. Well, this decreases the oxygen in pulses, in short intervals of 30, 60, or 90 seconds, mostly 30 or 60, from 21% to 9 or 10%. So there is this on and off, 30 seconds on, 30 seconds off, or 60 seconds on, 60 seconds off. What that does, it triggers neuroplastic changes into the nervous system that have been proven in individuals with incomplete spinal cord injury to improve motor performance. And specifically, it has been studied in gait. So individuals that undergo this intervention, and this intervention again is done in 5 or 6 sessions. So it's 30 minutes worth of this on and off hypoxic episodes, followed by motor training. You practice the task that you want to achieve. If you want to improve gait, you practice gait training. In our clinic, we also use it for hand function. So we pair AIH with the robotic training, or FES, mass practice. Let's put it mass practice of the hand or mass practice of the lower limbs in order to achieve whatever function we want to do. So you only need 5 or 6 sessions. That means truly 5 or 6 days. So you come here for 2 weeks, you do 3 sessions in 1 week, and 3 in the other, or if you want to put them all for a day, for 5 days in a week, you do it, and at the end you have better gait and you have better hand function. Now we don't know yet how long those, and this is what we're looking at right now. We're having recurrent bouts of care with acute intermittent hypoxia to see what's the frequency at which we need to apply the intervention. The intervention sounds weird and maybe dangerous, but it's nothing different than climbing Kilimanjaro, that sort of hypoxia. Some people tolerate it and some people don't. Obviously, it's a trial and error type of thing, because some people do not tolerate being up on Kilimanjaro.
So do you do that with children as well?
No, we don't, because the evidence-based data shows that it works in an adult with incomplete spinal cord injury. So we don't yet know what the hypoxia, what the neuroplastic change induced by hypoxia will be in a developing brain. So we're going to wait and get, first be safe, and the Hippocratic Oath says first do no harm. So, and then, have no boundaries. Oh, that wasn't in the Hippocratic Oath. It's an addition.
Yeah, exactly. So now talking about that therapy, some people might get that confused with a hyperbaric oxygen chamber. So can you explain the difference? Because they're completely different things.
Yeah, the hyperbaric oxygen chambers, you get put into part of your body, or your whole body gets put into the area in which there is high pressure oxygen delivered. This is hypoxic, so it's low oxygen, high, low. The pressure is high in the hyperbaric oxygen chamber, and in the acute intermittent hypoxia, you are at atmospheric pressure, at the pressure of regular environment.
And then somebody had a question about in doing these, would breathing exercises where the breath is held for a number of seconds result in similar results to the intermittent oxygen mask therapy?
I do not have any data about that. I am pretty sure that we cannot hold our breath until the FiO2, the oxygen level, drops to 10%, because oxygen and hypoxia is a very, very strong trigger for breathing. So, and if somebody else holds our nose and our mouth closed, they're going to suffocate us. So, so the idea is control delivery of a sufficient amount of oxygen, so there is no hypoxic damage to the brain or the CNS, but just the trigger that elevates the ability of the damaged nervous system to rewire, in the sense, or upregulate the receptors in order to be more receptive. The receptors would be receptive, oh good Lord, to the level of motor demand.
So yeah, so you're limiting the oxygen intake as opposed to cutting it off completely. So like,
yes, we're not, definitely not
cutting it off.
No.
Yeah, so probably
it's more like scuba diving when your oxygen is running out. The tank is running out, go down, you breathe less. But I did want to mention one thing about breath control. Breath control has a really important role in how we approach how we respond to the environment. So if we're anxious and we breathe very fast and shallow, the ability to perform a motor activity is impaired by that. We have hypercapnia, we get a little bit dizzy. So practicing breath control is actually, in one way or another, not only that it calms us down, but it allows us to perform the function better. And in this case, we're thinking motor function. So yes, breath control would work.
So would you recommend things like use of an incentive spirometer to help strengthen lungs? Because I recommend that a lot. There might be other things you might recommend, because people worry about their lungs and their lung capacity quite a bit, and they're always interested in ways to strengthen their lungs. So are there other things that people could be doing at home?
Yeah, so incentive spirometer helps with expanding the alveoli, which is the lung cell. Resistive training, like power lung, so breathing against increasingly smaller diameter straw is a way of resistive training, strengthening your respiratory muscles, your expiratory and inspiratory muscles. And resistive training is known to increase muscle hypertrophy. And don't get me started to the role of muscle mass. Actually, I will get started for a little bit for the role of muscle mass, only because it is such an easy goal to accomplish. We know how to maintain or increase muscle mass. It's not rocket science by now. And muscle mass equals or leads to better function. We started with the lung, yes, resistive training against this progressively decreasing diameter straw improves the strength of the inspiratory and expiratory muscles. We do the same resistive training for the residual muscles above the level of the injury, but we can use technology like E-steam and FES. And in fact, E-steam is a little bit better than FES in improving, in restoring muscle mass. But we have that ability to improve, to hypertrophy the muscle above and below. So thus improving function. We have data from children with acute flaccid myelitis, which is the polio of the 21st century. Is a lower motor neuron which responds poorer to electrical stimulation, but it does respond. And we have data showing that children that have better muscle mass have better function. You know, we know that if you have better muscle mass, you have better strength. But that better muscle mass to better function actually is not necessarily going through the strength. So there is some data that shows that, yeah, it improves the strength and doesn't improve the muscle function, but there is data in which the strength did not change, but the function, which is, we use the PAMS, the physical ability and mobility score, which is validated in children with both spinal cord injury and children with traumatic brain injury. So we use that, and it has 20 different domains of activity, anything from sitting, standing, moving, breathing, and so forth, including activities of daily living and so forth. So improving the muscle mass improve the PAMS score without necessarily improving the strength. Now, it could be just a statistical fluke, because we had this, you know, not hundreds of children, there are only 600 and something children with acute flaccid myelitis in the whole world, as far as we know right now. So we didn't have hundreds and hundreds in that study. We had, our study had 70 something children, but it was enough to draw statistical conclusion. So we're going back to, yes, resistance training of the lung. We can use the power lung, which you can buy it off the internet. You can use the incentive spirometer, which increases the ability of the lung cell to expand, so it doesn't stay collapsed. So the exchange of the gas is there. And then using the strengthening, you can cough better. The diaphragm is a very good back extensor. So improving your diaphragm strength, it improves your sitting position, which in turn improves balance, improves reach, arm reach, and so forth. Exercise is wonderful.
It really pulls it all together, doesn't it? And I think even about people just doing range of motion. So a lot of people don't have access to advanced therapies. They would love to have advanced therapies, but they don't have access to them. And it seems to me like a lot of people write in, I've given up range of motion time because I have so many other things I have to do. I have to cath, I have to shower, I have to do my bowel program, and there's just not enough time. But I keep trying to get them to go back to those range of motion exercises because it's the foundation of keeping your body in pristine condition, keeping your joints, keeping your muscles active, keeping everything in position, moving. It's a therapy that can be done without equipment, without a lot of assistance oftentimes, and just it's
yes,
it's a foundation block.
It's a low-hanging fruit. And I know that I mentioned pain before, and I think you also mentioned that there were some questions about pain.
Yes.
Keeping active. If you imagine if you're an able-bodied individual and stay in bed for 6 weeks in a row, are you going to hurt? Yes, I'm going to make that statement. You are going to hurt. If you lay in bed for 5 days and even without getting up and going to to do something that requires physical effort, just laying down, you're going to have increase in pain because of inactivity. Well, range of motion is that first step in restoring activity. So yes, it is the low-hanging fruit. I personally think that that's not enough. And again, I'm going to go back to the fact that you need to eat well, you need to sleep well, and you need to move well. If you do all those three, you live better. And in order to be able to work well, you need to live well, because otherwise, if mother is not happy, nobody's happy.
That's right.
Happy International Women's Day.
Oh yeah, yes, absolutely. A gentleman has written in a question that he was doing activity-based therapy and it was transformation for him. So that is wonderful. His T7 complete, and he participated in 2017 and continued at various therapy locations. He's 76 now, lives alone, completely independent, self-sufficient, enjoys a good quality of life, thanks to his introduction to activity therapy by the Reeve Foundation. So thank you for that shout out. His question is that he's learned he must stay active, and he really wants to do weight-supported therapy, but it's not widely available. He's a vet, but he can't get into vet programs on the East Coast. And he says, do you have any information on weight-supported therapy machines that you can use at home?
Well, so I'm going to say that being a true conflict of interest avoidant person, because I work in the academic realm, I try to keep myself free of conflict of interest, so I cannot recommend specific products. Because I don't think that there is one that's better than the other. Well, there might be one that's better than the other, but that's not the point. I deal in principles, but I can ask people that I work with and have that information in the form of specific names. I can give that list to you at a further time, and you can give it specifically to people that request it. I truly am not here to support any product,
right?
Except activity.
Right. Well, and yes, and there's a lot of inventions and a lot of startup companies for all of this type of equipment to make it more accessible to people in homes. And like you, I don't recommend any particular product. I do know of one company because they called me, and it's called Healing Innovations. It's out of Nashville, and they're creating a local mat type of weight supported walker that people can use in their home. They have a business model where they're trying to develop equipment that you would use in a facility, and then you would graduate to one of these home products. And again, I just look up home weight supported walking and see what you find on the internet, and keep looking throughout the months ahead, because there's a lot of people that are coming up with these ideas. But these people did call me and they told me about a product, and I thought it was pretty cool. But I don't recommend anything. I just mentioned that I have this piece of information. So
and I don't know if you remember, when we were back in St. Louis, there was a certain gentleman from Illinois, Bill W., that actually had a cherry pick and a treadmill, and he made a support. So he made his own partial weight supported walking.
And a lot of people do. A lot of people look at equipment, and they have friends who are handy, and they make these different kinds of equipment. And so, yeah, some people have gone that route and have done very well. Some people have had some problems because, maybe that wasn't set up quite the way it needed to be. And before you start any of these activity-based programs, you need to check with your healthcare professional to make sure that your body is equipped to be doing these kind of things. So here's somebody who writes in, and they want to know about the dancing molecule injections.
I made the point that I'm doing ANC, activity and technology. I'm not doing biologic. That is not my strong suit.
Yeah, well, that's fine, because I know that's still a lot under study now. So I don't know.
Everything in biologics are under study, and they're all phase 1, 2. So, we can make a blanket statement. There are a lot of biologics that have, that present promise.
Mm-hmm.
They are at the point in which they are transitioning to phase 1 study is safety. Just make sure that they're okay. Phase 2 is some efficacy. So that's where they are. There is not one biologic right now that I can tell you, you go take this one and you're going to get improvement in neurologic function. So I think, as a general statement, that's valid, but there are a lot of researchers that spend their life, like Dr. Jerry Silver and the Miami Project, with their cellular interventions. There are some pluripotent stem cells that are being tried. All of them are valid studies as long as they are done under an FDA approved or European patient protocol. As if anybody goes to a study and is asked to pay money, that is not a good protocol. And I advise against doing that. All of the research scientific studies with biologics will have strong inclusion and exclusion criteria, will have a strong basis from which they took it from the animal base to the translational part, will have a medical monitor to make sure that there are no consequences, and if there are adverse events, they are being dealt with. And most of those adverse events are not charged to the industry. They're part of, everything is taken care of under the umbrella of the study. So that's the study that you need to go to.
Right. And you can find those on clinicaltrials.com. Any approved study will be on there. And even if you go to that site and you think, oh, well, here's a study, but it's in Southern California, and I live in Northern New York State. I can't get there, but they'll put their findings on the clinicaltrials.gov, so you can take that information to your healthcare professional and say, do you think this might be something for me, and work out something with your own healthcare professional. So you can get a lot of information from those studies, but always go to ones that have some kind of monitoring to them. If like Dr. Sadowsky says, if there's a fee being charged and you have to pay hundreds of thousands of dollars or even a couple of $100, you shouldn't have to pay for clinical trials. That's kind of part of the deal. You're providing your body, so you shouldn't have to pay. There's somebody else who's written in a question about neuropathic pain. So can you just go through the hierarchy about treating neuropathic pain? Because a lot of people, there's been several questions. They're all taking Lyrica 200 milligrams just once in the evening. Maybe it's time to reevaluate that if the pain's not under control. So could you just walk through the steps, the hierarchy of treating that neuropathic pain?
Yeah, so we have modalities, obviously. So modalities are from the simple, the range of motion, stretching, electrical stimulation / TENS. We can use electrical stimulation to drive some medication in, like phonophoresis or ultrasound to drive the medication in, like iontophoresis or phonophoresis. That works more for musculoskeletal than neuropathic pain. But first, we do physical modalities. I didn't mention the TENS, the sensitization, compression garments, and so forth. So those are the things that have the least amount of side effects. Then we move into pharmacologic management. And pharmacologic management, it always needs to be done either by your spinal cord injury medicine professional or probably a pain management, because there are different levels of intervention. So you're going to try to modulate the amount of neurotransmitters that are inducing the pain or creating the pain. So most of the medications that we use in pain management are down regulators, and there are in different categories. So you mentioned the pregabalin, the Lyrica, or gabapentin, the Neurontin. Those are good, strong neuromodulators. I do recommend that you maximize one dose before you say that it doesn't work. So 200 at nighttime of Lyrica, which is the pregabalin, is not the maximum FDA approved dose. Is 600 and 3 times a day intervention. So if you only take a little bit of it, it doesn't last, and you don't know if it really works or not. So that's one of the principles of treatment. Then there are tricyclic antidepressants that are not being used for the treatment of depression, although yes, people that have pain will have more depression or vice versa. It's kind of a catch-22. So tricyclic antidepressants are being at smaller doses than the FDA approval for depression treatment, like amitriptyline, nortriptyline, and so forth. They have been shown to downregulate the neurotransmitters that are involved in pain transmission and thus modulate neuropathic pain. I have to make a strong statement. We do not cure neuropathic pain, we modulate it. So I'm going to tell you what my patients say after 10 years of treatment. Is like, how is your pain? It's like, it's there. What's the number? It's 8, but I live with it. That's the goal. It's not the number, is I can live with it. And I can live with it well is even better. Now, there are people, a small amount of people, probably 5% that the individual with spinal cord injury that will not have neuropathic pain, and but everybody else does. So in one way or another, neuropathic pain is part of the constellation of symptoms and in spinal cord injury. So we talked about pregabalin and gabapentin. We talked about tricyclics. I'm really excited about SNRI and SSRI. This is another group of antidepressants that have a role in treatment of pain. Again, not at necessarily at the same dosage as the antidepressant indication, at lower doses. I will give a specific shout out to Cymbalta because that has been FDA approved for, not only for neuropathic pain, but also for pain of musculoskeletal origin. So it can be used as one, getting more than one birth. So for physical modalities, then we move to pharmacologic management. Then there are some procedures that can help. And if we're specifically talking about neuropathic pain, we have to identify if it is a central versus a peripheral cause, because if it's a peripheral cause, like a nerve entrapment, there are specific interventions. If you have a nerve entrapment like carpal tunnel syndrome, that gives you not only hand pain, but carpal tunnel can give you the whole arm pain because it's retrograde transmission of the same pain. You have a steroid injection with lidocaine, or you have a decompressive surgery, and you're going to address the pain, the neuropathic pain. So there are those types. Blocks can be diagnostic, and the first and foremost role of the block is to be diagnostic. Is this the cause of your pain? So I'm putting lidocaine, and it stops the pain then and there. That means, yeah, this is probably the source of your pain. Now you can combine that with steroids or epidural or facet injections and so forth, and that is also therapeutic block. And then there are interventions that surgical implanted stimulator, although I'm going to say that the implanted stimulator for pain does not work very well for neuropathic pain and spinal cord injury, but it works. It has been repurposed. The same implanting stimulator for that Medtronic created for pain management has been reprogrammed. So it needs to be reprogrammed for epidural spinal stimulation. It's the same system, but it's completely different characteristic of the neural stimulation. So don't go to the pain management doc and say, hey, put an implanted stimulator, hoping that you're going to get the motor and sensory function recovery, because that doesn't work like that. And in fact, that stimulator doesn't work very well for pain management. But it's done with a trial. So before it gets implanted, there is a trial into the office. And if it works, it gets implanted. If it doesn't, you didn't lose anything except seeing that provider. So it's a worthy step. And then there are some surgical intervention that I will not even mention, because like DRES and cordotomy and hemi sections and so forth, that I have no. I'm a preservationist. I try to preserve tissue and improve function. So I will not necessarily, those are extreme cases that I would recommend that.
So that there is the hierarchy of the pain treatment. So that's good to know. So there's a lot of options if you've just been on Lyrica on a small dose, and you know that you have options that you can further move ahead with. So you can ask.
Can I plug, actually, in Monday, the 13th, we have the annual Trends in Spinal Cord Injury Symposium. It's a virtual, it's a hybrid event. You can find the information at kennedykrieger.org. It is all 3 hours worth of speaking about pain in spinal cord injury. We have a physician and a therapist, and that are internationally known in pain management. So yeah, please go to and join us in the seminar. You know, knowledge is power. So
that's what I'm saying. As long as you know that this stuff is out there, it's up to you to decide if you want to participate in it or not, but it's good to follow it along. Some people are ready to jump right on with let's get going with whatever the latest thing is or whatever treatments are available. Some people are a little more cautious and they want to wait a while and see how it works out for other people. And some people are not interested in some of these therapies at all. And that's fine too, because they're doing well with the way that they are and they're happy the way they are. And that's great. But knowing that this stuff is out there, and then that can help you decide if you want to participate, or if you don't, you'll know why you don't want to participate. So you have a lot of available things at your facility. It's completely built up for restoring function for individuals. That is the goal of the whole program. If you're out in the world and you can't get to your facility for one reason or another, or you're working someplace and you don't have these options to offer patients, what are some alternatives that people can do?
Well, so I'm going to say that activity-based intervention or training is kind of ubiquitous now. If you are near a spinal cord injury center in United States, if there, and it doesn't have to be necessarily in form of therapy. I think I might have mentioned, so training, there are groups, there are self-support groups, there are individuals that I know, they have a spinal cord injury, they purchase one piece or two pieces of equipment, and then they create gyms around, and I know that those are everywhere. Right now I can come up with one in Alabama and one in Orlando, knowing that they are. I know that there are several in Maryland and New Jersey and so forth. So getting on in some of these groups like CDRF or Asia or ASCIP or PVA, participating in in the spinal cord injury groups would give you the information on where to go. If you have a physical therapist that you have a relationship with, or a spinal cord injury medicine providers, that they can give you a home program, a home restorative program that can be done with equipment that is really easily accessible, like bands or an electrical stimulator that's $140, or put you in a clinical trial that uses activity, because there are a lot of small trials that are being done without a biologic or a technologic, but just for exercise. I don't know if I'm answering what you're saying. Is that I know you just have to look. Resources are everywhere. It's not, yes, there is technology, there is a home exoskeleton that's $70,000. That's not what I'm talking about. I'm talking about resources that are commonly available. They are present in your gym. A lot of the gyms are now inclusive and have a disability or a different ability equipment. I know that my unit has two, and now we're getting a third location in which we have trainers, and that we put into an adapted gym, and they are available either as individual training, or available. But the gym is available for you just like you go to a regular gym. So the same things are available in a lot of locations, and it doesn't take a $50,000 piece of equipment to do activity. There are things that are $400, and everybody can have one at home and not hang clothes on it.
And I want to reiterate, there are a lot more neurologically focused gyms that are opening up across the country in all kinds of places. The Y has adaptions. You can go down to your local gym and just go in and see what equipment they have, and they have a lot of adaptive equipment there. You can also call the Christopher and Dana Reeve Paralysis Foundation and ask for locations near where you live. You can Google adaptive gyms by my house, near me. And then also don't forget the peer mentor group that's available through the Reeve Foundation as well, because once you connect with other people in similar situations and find out, oh yeah, I go to this gym, they'll even have information about, it's really easy if you go to this dentist, I can get into their office. I mean, there's just all kinds of resources. Once you start connecting and networking with people, you'll find a lot of opportunity. So I see we're at the top of the hour. So I would like to thank Dr. Sadowsky for giving us a wealth of information today and very exciting news. It's always nice to talk to somebody who's enthusiastic about what they do and happy with what they do and excited about what they do. So it's just wonderful talking to you. Now, I see that you have on your website that you practice, of course, in Baltimore, Maryland, but you also have licensure for telehealth in Florida and someplace else.
In Florida, West Virginia, and I have a full license in Virginia. As of in about a month, I'm obviously licensed in DC, and then I'm going to get a license for Pennsylvania. Those are areas of catchment, and in the spirit of inclusion and accessibility, telehealth is one of the goods that came out of this pandemic. It is kind of going away in one way or another, and I'm trying to keep serving the people that reached out. So I am practicing telehealth in all those states. Our center does see patients from all 50 states and 50 international countries. We do accept most of the insurances. Don't ask me about insurances, but yes, we practice the ABRT that we deliver is covered by insurance.
And so people would be able to come to your facility after they have, they could go there probably for their initial rehab, but mostly
we do not have inpatient adults. We only have inpatient for pediatric.
So after you have finished your rehabilitation and you want to advance your progress, you might look up Dr. Sadowsky at Kennedy Krieger for an additional rehabilitation. That might be an option for some people. So thank you very much for being on the show today. It's always nice to see you, and I see you again sooner rather than later.
Well, hopefully see you at Asia in Atlanta, but if not, we'll find a spinal cord injury friendly environment to see each other. Thank you for having me. I really appreciate it.
Absolutely. Thank you for being on the show.
Bye-bye, y'all.
Bye.